and the ability to comprehend the test questions and answer them correctly. Help us successfully finish it according to your will. In the mighty name of Jesus our Lord. Amen. St. Thomas Aquinas, pray for us. So, Dr. Balate, we leave the floor to you. Thank you.
Okay, good evening guys. Can you see my slides? Okay naman. And yung audio, okay ba yung audio?
Yes po, Doc.
Okay, sige. So for those who don't know me yet, I'm Eric Balete, yung Clerks Monitor ng Department of Ophthalmology. So I was tasked to give you guys a review for your upcoming Revalida. So ito yung ginawa ko, no? I'll make it very concise lang and kumbaga straight to the point na para hindi niyo makalimutan yung mga must know. I'll discuss yung mga I'll give you tips on how to do your PE, your history taking, and yung mga most common makikita sa OPD na you will probably get na cases. I will also discuss yung mga must rule out diseases. Yung mga very important na yan. Okay, so recording naman na, no? I'll
Yes,
start
Doc.
na. Okay, sige. If you have any questions, you can interrupt me anytime naman. Okay? Sige. So, for this evening, I'll teach you guys how to be an eye doctor, no? Sige. So, let's start with history and PE do's and don'ts. Sige. For the chief complaint, okay, so what you need to do is to elicit the main reason that prompted the consult, no? And also in ophthalmology, it's important to specify the laterality when we indicate what the chief complaint is. So for example, blurring of vision, you need to indicate is it both eyes, right eye, left eye, both eyes, pero yung right more than the left, ganun. Okay, and then with the chief complaint, you also need to be very concise and specific, no? For example, patient came in with diplopia. So, anong klaseng diplopia ba yun? Is it horizontal diplopia or vertical diplopia? No, horizontal meaning magkatabi yung two images, vertical meaning magkapatong yung two images. And then is it monocular diplopia or binocular diplopia? So from that alone, no, halimbawa yung chief complaint mo, sasabihin mo as monocular horizontal diplopia, marami ka ng kumbaga madami ka ng info na nabigay dun sa 3 words lang na yun, no? And also it's important to use medically accepted terms, no? Dati may nakita kasi ako mga dati nakalagay na yung chief complaint nila, for example, ano nga ba yung mga example? Parang sinasite nila verbatim yung sinasabi ng patient as the chief complaint, which should not be, di ba? So, for example, sabi ng patient na meron siyang lid mass, nag-start off parang size lang daw ng piso. So you will indicate doon na coin size lid mass. So it's better na to just indicate na nodular lid mass or 2 to 3 cm lid mass, gano'n. Okay. Tapos yung sa don'ts naman, don't write yung referral as yung chief complaint. So halimbawa, patient came in from pedia, so ni-refer to OPHTHA. So sometimes nakikita kasi ako na naglalagay pedia referral as the chief complaint or FAMED referral, ganon. Then also don't write follow-up check-up as a chief complaint. So write niyo dun yung reason ba't siya nagpa-consult in the first place. So halimbawa, follow-up lang siya ng hordeolum. So ang chief complaint mo dapat would be upper lid, erythematous lid nodule sa may right upper lid, ganun, for example. And then, don't put diagnosis sa chief complaint mo. So, yun, for example nga, nilagay mo chief complaint, hordeolum. So, diagnosis na yun eh. So, you should put it as lid mass muna. Then, yung location ng lid mass. Okay, next. Sa HPI naman, so you need to keep it short, concise, but complete. And you also need to mention yung pertinent negative. So, I would argue na yung pertinent negatives nga, minsan mas important pa siya dun sa mga pertinent positives eh. Kasi it allows you to rule out some of the more important na diseases. The next would include pertinent prior ocular procedures or surgeries. So, naoperahan na ba si patient before? Which eye? And kailan pa naoperahan, no? And then, sometimes, I think it's an underutilized technique, which is repeating back the HPI to the patient. So, if yung some patients kasi magulo sa magkwenta ng HPI, so what I usually do in those cases is repeat back the HPI to the patient. Make sure na I understood all of it in the proper chronological order and in proper sequence, no? Don't include unnecessary details. Again, it's a waste of time kasi sa Revalida, time is gold. So you need to be very concise and straight to the point when you do the history taking, and don't let the patient trail off. So you always need to be in control, no? Ikaw laging magtatanong, you will lead the patient to the pertinent findings na gusto mong malaman about the history. So here's an example of a very concise HPI lang. So chief complaint, bearing of vision ng right eye. 2 years prior to consult, noted gradual progressive blurring of vision of the right eye, described as cloudy or hazy vision. Interim, there was gradual progression of blurring of vision of the right eye, now with noted intermittent episodes of feeling of dryness in both eyes lasting minutes, relieved by frequent blinking. So pertinent negatives include eye pain, no eye redness, no flashes, no floaters, no subjective visual field defect. So very short lang pero madami kang na-convey na information. And yung mga information na kinonvey mo are all relevant and pertinent. So sa past medical history naman, what you need to do is prioritize yung mga relevant comorbidities. So which includes yung diabetes and hypertension in the field of ophthalmology. And then aside from that, you also need to ask about the degree of control. So di lang sapat na tinanong mo kung may diabetes ba or hypertension. You also need to know if nag-take ba sila ng medications for that, maintenance medications, and how often nila nakikita yung doctor nila for that. Then next, ask for history of ocular procedures and surgeries, and also history of ocular trauma. Ask for history of spectacle use if you think relevant to case, and if indicated, ask for maternal, birth, and neonatal history. So this applies more to the pediatric age group. So mga don'ts is to include in the past medical history what should be included in the HPI. So minsan kasi for example, history ng previous ocular procedures would be relevant to the HPI. So, dun mo siya ilalagay. Based on your judgment na lang siya eh. Do you think na relevant ba siya sa case or not? Okay. So, sa PE naman, with the visual acuity, so, na-emphasize ko na to during yung, siguro pag nagro-rotate ka sa OPHTHA, yan, you hear me say this all the time. So, yung mga do's is to prompt the patient to try harder. Sometimes kasi, tinatamad lang sila magbasa or tingin nila kailangan ma-perfect lahat ng letters pero 3 out of 5 lang yung kailangan mabasa nila sa line in order to consider that line as being read ng patient. And then if you're testing hand motion, hand movement, counting fingers, light perception, no light perception. Be sure to do it multiple times in order to be sure na hindi lang nakakachamba yung patient. Next would be to correlate the visual acuity to the history of the patient. So mostly this applies to cases ng mga cataract, di ba? So ma-affect kasi yung differential diagnosis mo depending on how worse or how okay lang ba yung visual acuity eh. And then next is to use the pen light to ensure that you have good lighting during yung Jaeger and yung Amster testing. Mga don'ts is don't let the patient squint kapag nagte-test ka ng visual acuity, no? And don't let the patient peek with the eye not being tested. And reminder lang na if you're testing visual acuity nearer than 20 feet, always use the denominator of 200, no? So walang dapat makita na 15/100, 10/125, ganun. It's always 15/200, 10/200, 5/200, ganun. Okay? With the Amster grid testing, be sure to always let the patient use their best corrected visual acuity. So, for example, mas malinaw yung patient with the glasses, edi let them wear their glasses during yung Amster grid testing. And then, if the patient tell the patient to always look at the central dot during the Amster grid testing, and again to use the pen light to ensure good lighting. Don't consider blurry lines as positive findings, no. Tinetest natin sa Amster grid is again scotoma and metamorphopsia. And yung blurry lines more of ano siya, kahit error of refraction, makikita mo siya, or dry eyes, sometimes may blurry lines. But that's not what we're after when we're testing for Amster grid. So when testing for extraocular muscles, yung EOMs natin, mga do's is to perform the Hirschberg or yung pupillary light reflex. So this is a quick test in order to tell if the patient has state nung orthoptic sila sa primary gaze, wala silang strabismus. And also when you're looking for the extraocular limitations during down gaze, always remember to lift the lids up para makita mo talaga yung pupil. Kasi pag nakatingin siya sa baba, yung lids nila nakababa din. So you need to lift those. Tapos when we're testing for EOMs, ginigrade siya from +4 to -4. So +4, ibig sabihin overacting siya, no? Lumalampas yung eyeball dun sa object na you are trying to make the patient look at. Halimbawa, you have a pen, yung eyeball niya lampas dun sa pen. If limitations naman, -4, hindi na siya gumagalaw, kumbaga. Yung eye niya hindi na nagfa-follow. Tapos, for swinging flashlight test, so we do this test for RAPD. Mga do's is to hold the lids open if needed and to cross the nose bridge with the pen light. And don'ts is to don't perform it too fast. No? Always give time for the pupil to react. So this is an example video lang. Yan. Diba? You're giving it time for the pupil to react. Yeah, may positive RAPD siya sa right eye in this case. Yeah, nagda-dilate. Okay. Next. So we'll go over yung mga common chief complaints and what could be the possible disease entities na would cause this. So note that yung mga differential na I would put this is not an exhaustive list, no? Ito lang yung mga most common na would probably be the ones you see in the OPD. Pero don't limit yourself to this mga disease entities need to also think outside of the box, kumbaga, and be more thorough. So first would be eyelid swelling. Ang first na i-discuss ko would be blepharitis. So blepharitis, that's inflammation of the eyelids, further divided into anterior blepharitis, wherein it affects yung front ng eyelids, including yung lashes and the follicles. So common finding would be crusting at the base of the lashes, eyelid erythema, dry eyes. So mga symptoms ng dry eyes, including foreign body sensation, irritation, tearing, intermittent blurring of vision, photophobia, and yung rapid na tear break-up time. And aside from that, you could also see punctate epithelial erosions, which are parang maliliit na sugat sa harap ng mata that's caused by dry eyes. Okay, so kumbaga yung most pathognomonic in this case would be yung crusting at the base of the lashes. So this is what you see in the picture in the lower right. No? Sometimes you also see eyelid erythema. Okay, so this is what dry eyes would look like on slit lamp examination. So I think pwede naman kayo gumamit ng slit lamp during your Revalida. So yung mga naturuan na, I think you would be familiar na with the slit lamp, and I think yung ano lang yung kumbaga challenging lang would be knowing yung mga different na eye drops na pinapatak. So for dry eyes, important yung fluorescein dye to assess first yung tear break-up time, and again also for punctate epithelial erosions. So tear break-up time normal niya is more than 10 seconds. If less than 10 seconds before mag-appear yung dry spot seen on the picture, you consider that as a rapid tear break-up time. So that's a sign of dryness. And then on the right, you would see ano yung itsura ng punctate epithelial erosion. So para lang siyang mga pinpoint na uptake, dye uptake that would glow up with the blue cobalt blue light. Okay, and eto naman itsura ng severe dry eyes, no? So pag severe dry eyes, yung tear break-up time mo, very rapid na, less than 5 seconds na lang. Then yung punctate epithelial erosions would be very extensive, no? Very diffuse. Parang nakikita niyo sa picture na yan. So next would be posterior blepharitis. So ito naman, it affects the posterior part of the eyelid, which includes yung meibomian glands natin and yung labasan ng meibomian glands. So posterior blepharitis is primarily caused by dysfunction in the meibomian gland. Makita nyo, meron siyang what we call yung inspissated or yung blocked meibomian glands. Para siyang barado na glands as seen in the picture. So again, anterior blepharitis would be yung crusting sa mga lashes or yung collarettes na tinatawag. Pag posterior blepharitis naman, it's the inspissated or the blocked meibomian glands. And again, you would present with symptoms ng dry eyes. So ano yung management natin for blepharitis? So anterior or posterior blepharitis, ang management nila is the same basically. So most important would be eyelid hygiene, which comprises of yung warm compress natin. So we do warm compress para matunaw yung mga bara-bara dun sa mga oil glands or sa mga meibomian glands natin. So this is done 10 to 15 minutes, 3 times a day or 2 to 3 times a day to both eyes. Aside from that, we also do yung eyelid scrub. We do this with baby soap or baby shampoo para kahit pumasok sa mata ng patient, di siya mahapde, no? So seen on the picture is how we instruct to do yung eyelid massage and yung eyelid scrub. So eyelid massage, basically parang pinipiga mo yung meibomian glands in order to extrude yung contents niya. And then eyelid massage, again, that's yung eyelid scrub, that's cleaning yung eyelashes mo with the baby soap or baby shampoo. Aside from that, we may also give lubricants. So ang most common lubricant na binibigay namin para madaling i-memorize, ito na lang i-memorize nyo, is hypromellose eye drops to both eyes 4 to 6 times a day, no? And if severe yung dryness ng eyes, no, we could also add yung mga mas malapot na lubrication, which is yung Systane gel drops, and yung Carbomer eye gel. Any lang naman sa dalawa na to. Okay? And then for chronic meibomian gland dysfunction, halimbawa, tagal na nagfa-follow up yung patient sa'yo, hindi pa rin gumagaling yung meibomian gland dysfunction niya, consider adding doxycycline na oral antibiotic na to. So doxycycline, 20 milligrams per capsule, 1 capsule twice a day for about 2 weeks. So next would be hordeolum or chelation. So ito medyo familiar na siguro kayo. Hordeolum would be the inflammation of the oil glands nung sa eyelid margins, no? So this is caused by meibomian gland obstruction and or inflammation caused by the normal flora nun sa skin. So it's further classified into internal hordeolum or external hordeolum, depending on which glands yung affected. So internal pag meibomian and external kapag glands of Zeiss or Moll. So the picture on the top would be an example ng internal, picture on the bottom would be example ng external. So as you can see, it's important to avert the eyelids during examination if you're thinking of hordeolum or chelation. Kapag chelation naman, this is a chronic or long-standing hordeolum. It's typically painless compared to your hordeolum, which is tender or erythematous. It's typically painless but may also be tender due to inflammation of the meibomian glands. So yun lang naman yung difference ng hordeolum and chelation is the presence of acute signs of swelling. Tapos, so let's start first with hordeolum. Findings would be again localized tender erythematous elevation of the eye at the eyelids with a pointing eruption, either on the inner or the outer side of the eyelids. So hordeolum is more acute, developing over days, and sometimes there's also pustule formation. So again, important tips is to avert the eyelids always and also check the other lids. Baka meron ding other hordeolum. Sometimes kasi may multiple hordeolum, no? Ang ibang people ano sila predisposed to forming hordeolums. Okay, so for chelation naman, ang finding would be a non-tender naman. Non-tender, non-erythematous eyelid mass. And usually it's long-standing. Mga hordeolums na hindi na gumaling, so naging chelation na sila. Again, avert the eyelids and check the other eyelids. Baka multiple chelation yung patient. If recurrent yung chelation, it's important to do biopsy to rule out malignancy. Yung paulit-ulit yung yung chelation. So for management ng hordeolum at chelation, it's similar lang naman. First, we do warm compress to the eyelid 4 to 6 times daily. So napansin nyo, very frequent yung warm compress, no? And then aside from that, we also give topical antibiotics. Tobradex usually, so may dexamethasone component siya. Yung dexamethasone component, yung steroid component, it's very important to parang pahupain niya yung inflammation ng hordeolum. It could also be used sa chelation. Sometimes pag may chelation yung patient, we do trial ng Tobradex ointment muna and see after 1 week if lumiit ba yung chelation, no? If internal hordeolum, you may also do, actually, if hordeolum, you may also try oral antibiotics. Some of our consultants, they prefer using oral instead of topical lang. So if you want to do oral, ang example dun is coamoxiclav, 6 to 5 milligrams twice a day for 7 days. And then, siyempre ifa-follow up mo siya after 1 week. And if unresponsive yung hordeolum or chelation, no, persistence pa rin, you may consider doing incision and curettage. And after that, no, if after incision and curettage, nag-recur pa rin, again, consider doing biopsy na dun sa eyelid mass to rule out malignancy lang. Okay, so next would be cellulitis naman. So divided into two, preseptal and orbital. So ang important dito would be differentiating between the preseptal and the orbital. Okay, so preseptal is inflammation of tissues anterior to the orbital septum. Orbital naman would be posterior to the orbital septum. So both of these are caused by an infection process, no, either due to direct inoculation, pwedeng na kagat ng insekto, no, or spread from contiguous structures. Halimbawa, may long-standing hordeolum, dacryocystitis, yan yung mga nakalist na infectious diseases. Also could be through hematogenous spread, no? So as for history ng upper respiratory tract infection or ng middle ear infection. And during your PE, would be prudent to check the lymph nodes na lang rin to check for lymphadenopathy. So preseptal versus orbital. Kapag preseptal, that's usually presenting with, both actually would present with eyelid edema and erythema. Kapag orbital cellulitis, pwedeng magkaroon ng decrease in visual acuity, pwede din magkaroon ng RAPD and reduced color saturation because of naiipit yung optic nerve, no? Then you can also have chemosis sa conjunctiva and proptosis due to involvement of the soft tissue sa orbit. And as well as yung limited yung extraocular muscles mo. Again, due to involvement ng soft tissue sa orbit mo. Okay? Ito pala medyo specific tong finding na to, yung pain on movement. So pag ginagalaw ng patient yung mata niya, looks up, looks down, looks left, or looks right, sumasakit siya. So that indicates involvement na nung orbital structures mo. So this is a sample case ng orbital cellulitis. So visual acuity of this patient is relatively normal, 20/20. Pupils niya, negative naman for RAPD. Lids and lashes is essentially normal sa right, pero sa left, you note erythematous and edematous lids. Meron din siyang proptosis na medyo mild if you are able to see it or appreciate it. Conjunctiva niya is normal, so wala namang chemosis. Ito, on worm's view, mas ma-appreciate mo yung presence ng proptosis, although very mild lang siya. And then, ito yung mas specific na finding, no? On motility testing, meron kang limitations sa EOMs niya dun sa left eye. Meron din siyang noted diplopia in all fields of gaze, and meron din siyang pain on left lateral gaze. So, pag narinig mo yun, medyo sure ka na could be orbital cellulitis. So management would be kapag immunocompetent, febrile naman yung patient and medyo mild lang yung preseptal cellulitis, you could try oral antibiotics. If immunocompromised yung patient naman or less than 2-year-old or may fever na siya and tingin mo medyo severe yung preseptal cellulitis, medyo warranted na to hospitalize the patient for IV antibiotics. So IV antibiotics would be ceftriaxone. Pero for some kaya pa rin nilang gusto pa rin nila i-try yung oral man lang. So if you want to try oral, you need close monitoring. Tapos admit agad yung patient if no improvement with the oral antibiotics. So if orbital cellulitis naman, outright admission is warranted. We can also do imaging in the form of orbital CT with contrast, no? Imaging to assess the orbital structures or to rule out orbital abscess. Then it would also be prudent to do blood cultures and yung yung IV antibiotics na tayo. Okay, so next would be eye redness naman. Ang differentials natin dito is conjunctivitis and subconjunctival hemorrhage. Pero hindi naman siya limited to these two diseases. So let's start first with conjunctivitis. This is further divided into non-infectious and infectious. So for non-infectious, you have allergic conjunctivitis, which is the most frequent cause ng conjunctivitis. And then for infectious, you have viral and bacterial. So for allergic conjunctivitis, ang important to elicit is a history of allergic or atopic condition. So this includes eczema, asthma, urticaria, or rhinitis. And then on history, kumbaga ang pathognomonic finding would be yung pruritus, no? Kapag bacterial or viral, it would not present with pruritus. Then other findings would be thin watery discharge, eye discomfort or pain. Meron din sila parang foreign body sensation, parang gritty or sandy feeling minsan sa eyes nila. And also, you would note chemosis sa conjunctiva. Chemosis is a non-specific finding, no? But it's often found in allergic conjunctivitis, sometimes in bacterial conjunctivitis. Then, kapag conjunctivitis, you also need to avert the eyelids. Ang makita mo sa allergic would be papillae, although honestly, this is medyo mahirap siya actually to differentiate yung papillae from follicle. Kapag kapag medyo red, usually papillae yan eh. And you see on the picture on the right, no, merong picture ng giant papillae. So very obvious na dito yung papillae, medyo nakakatakot siya tignan, 'di ba? So this is a very telltale sign ng allergic or vernal conjunctivitis. Vernal conjunctivitis is just another word for allergic conjunctivitis. Okay, so next would be viral conjunctivitis naman. So this is highly contagious. So it's commonly with history ng close contact ng person with the similar symptoms, nagkakahuwaan sa household or sa workplace, no? Possible history also of recent upper respiratory tract infection. Again, check the lymph nodes during the PE kasi if there's presence of lymphadenopathy, that would tell you that it's more likely viral than bacterial. Discharge is characterized as watery or tearing, pero occasionally it could present with mucus discharge. And on lid eversion, you would note follicles instead of papillae. Again, it's difficult to tell eh. Medyo magkamukha kasi sila yung papillae and follicles. So, more of history yung pagbabasihan mo in differentiating between the kinds of conjunctivitis. Next would be bacterial conjunctivitis. So, this is characterized by a hyperacute onset. So, mabilis siya mag-develop o mag-progress. So, meron severe and rapid progression. And meron siyang mucopurulent discharge. So, kapag magmumuta yung patient, medyo malagkit yung muta niya. So, you would lean towards bacterial more than viral. Also found here would be severe chemosis, eyelid edema, marked conjunctival hyperemia, and papillae on the diversion. So, picture on the lower right shows papillae. Makikita mo talaga na medyo parang rough yung yung underside ng lid. And makikita mo sa taas yung presence of mucopurulent discharge. If starting off pa lang yung bacterial conjunctivitis, no, it's very difficult to tell it apart from yung viral. magkamukha kasi sila talaga kapag wala yung pagmumuta, no? So, based nyo na lang dun sa history na nakuha nyo. Anyways, yung management naman nila is similar, eh. So, hindi ka naman magkakamali dun. So, management ng allergic conjunctivitis would be first and foremost yung allergen avoidance, no? Next, we could also do cold compress to alleviate yung itching nung eye. And then we also give anti-allergy na eye drops. So OPHTHA din, that's a mast cell stabilizer. It comes in two preparations, 0.1 and 0.2. Kapag 0.1, you instill it twice a day, and if 0.2, once a day lang. Aside from that, you also give lubricants, no, artificial tears in the form of hypromellose na lang siguro para madali niyong tandaan. From those eye drops, 1 drop to both eyes, QID. So this would reduce yung parang feeling ng dryness sa eyes, yung irritation, and could also flush away yung allergens sa ocular surface. Aside from that, you could also give the patient oral anti-allergy. So cetirizine, 10 milligram per tab, ODHs. If that fails, no, if chronic na yung allergic conjunctivitis ng patient, we could start the patient on immunotherapy. So this is done by an allergologist. So refer na lang sa allergologist for immunotherapy. So this is where you expose the patient dahan-dahan doon sa allergen niya until ma-desensitize na siya. So for infectious naman, ang management would be first to educate the patient on conjunctivitis, no? Important na malaman niya na very very transmissible to. So we teach the patient to do frequent hand washing, to avoid sharing personal care objects, and to avoid contact with the eye. So, wag hawak-hawakan yung mata. We also recommend isolation for about 10 to 14 days or as long as the eye still looks red. Besides that, we give levofloxacin, so antibiotics, eye drop, levofloxacin 0.5 to the affected eye every 3 to 4 hours, depending on the severity, no, for 7 days. And we also give, you could also give tobramycin. So either levofloxacin or tobramycin. Even without the antibiotics, gagaling pa rin yung conjunctivitis, no? Yung antibiotics is just there to parang hasten the recovery ng conjunctivitis. Also as a patient to follow up after about 7 days, just to reassess, no, if pwede na ba siyang bumalik sa work, pwede na siyang di na mag-isolate. And if pwede na i-stop yung antibiotics natin. Next would be subconjunctival hemorrhage. So this is caused by bleeding, rupture in the small conjunctival vessels sa harap ng mata. This is usually asymptomatic but may cause mild irritation. So typical history ng patient, sabihin niya, napansin na lang ng kapamilya niya, ng relative niya na namumula yung mata niya, or biglang nakita na lang niya sa salamin na namumula yung mata niya. So it's it's painless and sudden yung onset. So usually hindi yung patient yung nakakapansin, kasama ng patient. And wala naman siyang ocular complaints bukod doon sa redness talaga doon sa eye. So it's very isang tingin mo pa lang alam mo na subconjunctival hemorrhage yun. It's characterized by yung sharply circumscribed bright red color dun sa conjunctiva, and you could also elicit history ng hypertension, ng straining, coughing or sneezing, which would cause transient increase in the blood pressure. It's also important to elicit kung if the patient is on blood thinners, meron ba siyang blood dyscrasia, no? So that includes patients on dialysis. Kapag tina-dialysis kayo yung patient, 'di ba nilalagyan din siya ng blood thinners in order for the dialysate ba yun? Or basta yung dugo niya para hindi mag-clot dun sa machine. Also people on chemo, mga patients on chemo, meron din silang blood dyscrasia, no, because of the chemo. So, aside from that, pwede ding may history ng ocular trauma. Halimbawa na nasundot yung mata, pwedeng subconjunctival hemorrhage due to the trauma. So, ang management is mostly reassurance lang, no? We need to explain to the patient na this will resolve on its own, na pwedeng maulit-ulit due to the presence nung risk factors pa rin, no? So, halimbawa, if may ano pa rin siya, may aspirin intake pa rin siya, syempre may risk of recurrence pa rin, ganun. And then we could also do cold compress for about 10 to 15 minutes, 3 times a day for the first 48 hours. So this would parang stop yung pag-progress nung hemorrhage. So parang pasa lang talaga siya na you put cold compress first 2 days. Aside from that, you can also prescribe lubricants, no, for relief ng mild irritation. In some patients, meron silang parang foreign body sensation, medyo mahapdi yung mata, ganun. So, prescribe hypromilus ulit, QID. So, next would be tearing naman. Patients who come in with chief complaint ng tearing, we could consider dry eye syndrome. So, this is one of the most common problems sa OPD. So, dapat alam niyo to kasi very prevalent siya. So this is caused by tear film instability. So normally the tear film is important in protection against the air, the environment, and it also contributes to refractive power of the eye. So if may defect in the tear film, that could present as irritation, no? So burning, stinging, itching sensation, medyo mahapde, sabi ng patient. Foreign body sensation, parang may buhangin sa mata or parang gritty yung feeling kapag pumipikit. Tearing, so nagluluha yung patient kasi parang kapag mahapdi yung mata mo, 'di ba, parang maluluha ka rin. Frequent blinking, so mapapansin niyo to kapag nag-examine kayo sa patient under the slit lamp na parang pikit siya ng pikit, wala ka na makita kasi lagi siyang pumipikit, no? So, can also present as eye redness, blurring of vision, or fluctuating blurring of vision. So, this is described to be worse when reading, driving, or with gadget use because these are the activities wherein less yung blinking natin eh. So, less blinking, mas nagda-dry yung eyes. Could also present with eye fatigue or eye pain or eye headache. Okay, so again this is yung appearance ng dry eyes on the slit lamp, tear breakup time of less than 10 seconds, and sometimes with punctate epithelial erosions. Again, what would appear, how the severe dry eyes would appear on the slit lamp. Very rapid T-bout of less than 5 seconds and very extensive yung punctate epithelial erosions. So management on dry eyes is basically just lubrication, which can come in the form of hypromellose eye drops, again, 4 to 6 times daily. For less irritation, you may opt for preservative-free na eye drops. So, ang hypromellose kasi with preservative siya eh. Sometimes yung ibang patient na-irritate sila, lalo na kapag madalas yung pagpatak nila ng hypromellose. So, an alternative would be Hayabac preservative-free eye drops. Less irritating siya. So, mas mahal nga lang. So, 1 drop to both eyes, Q4. No? If severe, you can add, again, yung mas malapot na mga lubricants natin in the form of Systane gel drops or Carbomer eye gel. So, next, meibomian gland dysfunction naman. So this is basically altered meibomian gland secretion and tear film abnormalities. This is more common with advancing age, although it could also be found in the young with excessive gadget use, exposure to wind or extreme sunlight conditions, and also in contact lens users. Again, yung telltale sign na makita mo would be yung inspissated or yung blocked meibomian glands. Also, again, would present with symptoms of dry eyes. So, mapapansin nyo, medyo similar lang to dun sa posterior blepharitis. And in a sense, it's basically the same disease on the, it lies on the same disease spectrum, kumbaga. Ang meibomian gland dysfunction, more of ano lang siya, yung tearing, and then posterior blepharitis is more of yung inflammation, but it's basically the same disease. Management, again, eyelid hygiene, lubrication, and oral antibiotic kapag chronic. So, same lang as with posterior blepharitis. Next would be lacrimal drainage obstruction. So, this is kapag may obstruction do sa lacrimal apparatus natin. So, this could present as excessive tearing. So, on the picture on the right, you would see example ng obstruction with the dye disappearance test. So, the dye disappearance test is basically positive kapag merong persistence ng fluorescein dye after 5 minutes. So, dapat kasi nag-clear up na yung dye by that time, no? Nade-drain na siya through the daanan ng luha. Pero kapag may obstruction there, parang magsi-stay siya within the eye. So, makikita mo sa picture on the lower right, merong asymmetric drainage ng fluorescein dye. Yung sa right eye niya, dami pang dye na natira. Pero yung sa left, wala na. Okay, so if you're considering lacrimal drainage obstruction, it would be prudent to rule out ocular cystitis na rin, no? By asking about purulent discharge for palpating yung area of the lacrimal sac for tenderness and looking for erythema dun sa lacrimal sac. Okay, so management for lacrimal drainage obstruction would be irrigation. So lacrimal apparatus irrigation. This is done by yung pagbomba ng lacrimal drainage using syringe, sterile saline, at saka yung cannula. So yung mga lucky enough to witness this dun sa OPD, so easier sa kanila para ma-imagine to, no? So yung irrigation is both diagnostic and also therapeutic for partial obstruction. Therapeutic in a way na pag binomba mo yung partial obstruction, may chance na ma-dislodge siya and maging patent na yung lacrimal apparatus natin. So this irrigation will approximate the site of the obstruction and will also determine if the obstruction is partial or complete. Ang management natin would differ if partial or complete. Kapag partial, pwede tayong mag-regular massage, which is basically massaging yung lacrimal sac in order to ensure na hindi siya mag-obstruct, parang hindi mamuo yung mga bara doon para ma-dislodge yung mga partial obstruction in the lacrimal apparatus. And papabalikin natin yung patient for monthly lacrimal apparatus irrigation or yung LAI. So every month sila babombahin ng tubig doon sa daanan ng luha just to make sure na hindi mamuo yung obstruction there, hindi maging complete yung partial obstruction. And we may also add topical antibiotics if may purulent discharge. Halimbawa, nag-irrigate ka and may lumabas na purulent discharge nung binomba mo yung daanan ng luha, you can also add topical antibiotics, the form of levofloxacin. Kapag complete naman yung obstruction, so the definitive management here would be surgery. So, medyo out of yung expected na to na alam nyo. Pero if you wanna be bibo, no, you could discuss na ang definitive management is surgery in the form of stent insertion or ng dacryocystorhinostomy. Okay, so next would be eye pain naman. Ang differentials natin, first would be corneal abrasion. So this is fairly straightforward. Corneal abrasion is loss of surface epithelium, usually due to trauma. So nakalmot, may tumama sa mata, nasundot, yun. So yung defect in the epithelium stains with fluorescein. Ang findings natin would be pain on the eye, aggravated on blinking. So mas sumasakit kapag may pikit sila kasi yung eyelid nag-rub off nun sa, kumbaga yung sugat sa harap ng mata. Patient would also present with foreign body sensation, no, parang may buhangin na na-stuck under the eyelids. Pwede din siya magka-eye redness, tearing, and photophobia. But the most characteristic finding, of course, would be fluorescein dye uptake, no? Kapag nakita mo na may uptake on the fluorescein dye, alam mo na abrasion na siya eh. It's very, kumbaga, very pathognomonic yung itsura niya. So a tip would be to avert the eyelids to check for foreign bodies, no? Especially if linear yung mga abrasion. So parang may gumagasgas sa harap ng mata. Could be na may na-stuck na foreign body dun sa eyelids, no? So it's important to remove that foreign body. Next, conjunctival abrasion. It's basically similar to the corneal abrasion, different lang kasi it lies on the conjunctiva instead of the cornea. Again, it's important to avert the eyelids to check for presence ng foreign body. So, pag merong foreign body, ang diagnosis mo kasama na doon would be conjunctival foreign body. So, conjunctival abrasion with presence of conjunctival foreign body. Management ng abrasion would be basically antibiotics lang and lubricants, no? So this is self-resolving, usually heals within days. Ang important lang is kapag may sugat pa, no, the first few days is hindi siya ma-infect. This is why we give topical antibiotics in the form of levofloxacin and lubricants na rin to alleviate yung foreign body sensation and yung irritation sa eye. Again, we follow up the patient after 7 days to make sure na nag-heal na yung abrasion, no? Usually, after mga 4 or 5 days, ano na siya eh, parang wala na yung uptake eh. Usually, lumiliit siya until biglang mawala na lang. And then, watch out for mga signs of inflammation, signs of infection, signs of infection basically, which is sudden blurring of vision, sudden increase in the redness, mucopurulent discharge sa eyes. Next would be corneal foreign body. So this is an occupational hazard, no? Karamihan ng corneal foreign body na nakita ko is mga men in their 20s or 30s, mga welder, construction workers, metal workers, sila yung mga usual na corneal foreign body. Kasi sila nag-work sila sa mga welding na walang eye protection, nag-grind ng metal without eye protection. Ayun. So, finding would be foreign body sensation, sudden onset pain aggravated by blinking. Kasi kapag nagbi-blink, natatamaan ng eyelids yung foreign body. Eye redness, tearing, photophobia, and this is grossly evident on external examination, no? So pagkatingin mo pa lang ng slit lamp, kitang-kita na yung corneal foreign body. An example of which is shown on the picture on the right. Again, since basically sugat siya eh, yung parang may bumaon na foreign body do sa cornea, tas nagsugat. So dahil sugat siya, meron din siyang fluorescein dye uptake. So ang management on this case would be removal ng foreign body. This is typically done with a tuberculin syringe. and done with topical anesthetics para hindi masakit, no? Important kasi na hindi gumagalaw yung patient during removal para hindi masundot yung mata. We could also do lid sweeping. This is done by parang kukuha ka ng cotton buds and parang isi-sweep mo lang yung superior and inferior fornices to make sure na wala ng trap na foreign bodies na nandun sa na trap sa upper and lower cornices. And then similar management siya with corneal abrasion kasi basically same siya na sugat siya sa cornea. So give topical antibiotics in the form of levofloxacin as well as lubricants in the form of hypromilose. Again, follow up after 2 to 7 days depending on the depth nung corneal foreign body, no? So kung gaano kabaon siya, how much yung natanggal mo. So natanggal mo ba lahat? Di kahit after 7 days na siya mag-follow up. If may natira pa, di kailangan niyo mag-follow up ulit para matanggal yung natira, no, after ilang days. And again, watch out for signs of infection. Next differential sa eye pain would be acute angle attack. So this is glaucoma. In the spectrum of glaucoma, it's caused by a rapid increase in the intraocular pressure due to outflow obstruction of the aqueous humor. So ang findings dito would be sudden onset ng severe unilateral eye pain. So sobrang sakit din yung description ng mga patient, no? Yung iba nga nagsusuka na. So can present also with headache, nausea, vomiting, blurring vision, halos around yung bright lights. On slit lamp, you would see marked conjunctival injection, as in pulang-pula yung buong eye, fixed dilated pupil. So hindi masyado nagre-react yung pupil to light, hazy cornea because of the increased intraocular pressure. Also, you would note shallow anterior chamber, no? And I know na hindi kayo pwede mag tonometry, pero you could just assess, parang estimate yung IUP with digital tonometry. Alam mo ba yung digital tonometry? Yung parang susundutin nyo lang yung, you would palpate the eyes through closed eyelids. Parang palpate nyo if kasing tigas siya ng forehead nyo. So that's very firm, no? Mataas yung IOP nyon. Usually, ang normal IOP kasing tigas lang ng nose, no? Yung tip of the nose, yon. So, this is pictures ng anterior chamber sa slit lamp. So, the angle is best assessed as the periphery. So, dun sa may limbus. Makita niyo sa picture na parang may two light beams. Yung first would be the light reflecting on the iris and the second would be the light reflecting on the cornea. So in between them would be the peripheral anterior chamber depth. And this is how we measure yung anterior depth, kung shallow ba siya or kung deep. If yung anterior chamber depth at the periphery is more than 1/2 the corneal thickness, angle closure is unlikely. So medyo deep pa yun. Picture A, makita nyo example lang shallow angle, no? So parang hindi nakasya yung 1/2 ng corneal thickness dun sa pagitan ng dalawang light beams. So picture B naman, kasyang-kasya yung 1/2 ng corneal thickness. So angle closure here is unlikely and masasabi natin na deep yung anterior chamber. So management acute angle attack, important to bring down the intraocular pressure by 30%. And this is done with anti-glaucoma medications, no? So the aim of the anti-glaucoma medications would be to block the production of aqueous humor. This is done by giving the patient acetazolamide and brimonidine plus timolol or Combigan. So acetazolamide is given 2 tablets now and then QID. Acetazolamide causes potassium wasting. So this is usually supplemented with potassium chloride tablets. 2 tablets now again, and then QID after. Ang Combigan naman, it's 1 drop to the affected eye twice a day. And then kapag napababa na yung intraocular pressure, medyo nag-clear up na yung cornea, no? Meron na tayong view of inside, pwede na nating i-laser iridotomy yung patient. So, laser iridotomy, this is done using laser. Bubutas tayo doon sa iris in order to make daanan ng aqueous humor, no? And to relieve the pressure. Again, this is done once IOP is controlled and once the cornea is less hazy. Okay, so next, I'll make this fast na. Blurring of vision naman. So, ito na yung last natin. First in this topic would be cataracts. Again, so cataract would be clouding of the natural intraocular crystalline lens. And these are classified into several types according to the etiology. Ang di-discuss lang natin today would be yung age-related kasi ito yung mas common and ito yung most likely makikita nyo sa OPD. Other than that, meron din traumatic and metabolic. So metabolic could be caused by diabetes, uncontrolled diabetes. So ang age-related is further classified depending on which part ng lens is cataractus, no? So pwedeng nuclear or yung gitna, cortical or yung gilid, and then posterior subcapsular or yung likod. So ito yung mga different appearances nila with the slit lamp. Ang findings with the cataract, usually makikita mo sa history, ang i-describe ng patient would be parang maulap yung paningin nila or parang mausok. So cloudy or hazy blurring of vision. Medyo sure ka na cataract yun eh. And typically the VA is worse on distance than in near. Ang VA nila markedly poor if makapal na yung cataract or if subcapsular cataract. Pag subcapsular cataract kasi, parang yung cataract is sakto sa gitna eh. Sakto sa visual axis. So, harang na harang yung yung paningin ng patient. Other findings would be yung tinatawag na second sight caused by increased myopia. Kapag nagiging cataractus kasi yung lens, less elastic siya, and this causes improvement near vision sa emmetropes, but worsening sa distance vision in the emmetropes. Aside from this, pwede ding poor vision in dark, decreased contrast or color vision. Again, kasi maulap or mausok yung paningin ng patient. So parang decrease yung contrast ng colors. This could also present as glare. This is more common with cortical cataracts. And rarely pwedeng describe ng patient as diplopia or monocular diplopia. So ang tip dito, if you are suspecting for cataract, it's important to extract history ng previous ocular surgeries. So baka naoperahan na pa rin yung cataract niya. So natanggal na. Nag-undergo na siya ng phacoemulsification. So on slit lamp, ang makikita mo would be a slight opaque or opaque lens on external eye examination. So ito yung mga itsura ng mga different lens status, no? Kapag na-operan yung mata niya, natanggal na yung cataract, so pseudophakic na siya. This would appear as parang very clear yung lens niya kasi artificial na eh. Parang unnaturally clear or transparent yung lens. So that's pseudophakic. Kapag normal or natural lens pa, yung clear lens, parang itsura niya, describe ko as parang medyo madumi na tubig eh. Pero puti pa rin siya. Kapag slightly opaque naman, medyo opaque siya and meron na siyang parang greenish tinge or sometimes yellowish tinge, brownish tinge. Kapag opaque, yan yung obvious na na makapal na talaga. Okay, so Again, these are findings depending on which part of the cataractus lens is cataractus, no? So nuclear, cortical, or posterior subcapsular. Kapag cataracts are also classified based dun sa kumbaga yung pagkahinog ng cataract, no? Kapag immature pa yung cataract, manipis pa siya, relatively okay pa yung VA ng patient. Sometimes nga 20/20 pa yung VA ng patient eh. So about mga 20/80, yun, mababa pa yun. Manipis pa yung cataract nun. So slightly opaque pa lang sila. Kapag senile mature cataract naman, it's a bit thicker, mas relatively poor yung visual acuity, about 100 to 2200. And on external eye examination, makita mo very opaque na yung lens niya. Pag hypermature cataract, these are very, very thick na yung cataract nila, brunescent na yung cataract. So, ang VA natin is very poor, mga 2200 na to about hand motion, counting fingers, ganun. Ganun ka worse na yung visual acuity. And you would see very thick na talaga, very opaque lens. Yan, yung example niyan dun sa lower right, parang sobrang dark na ng itsura niya. This is important kasi iba-iba sila ng management, no? Kapag immature cataract pa lang, you could try refraction, no? So, baka makuha pa siya sa glasses. If senile mature cataract, that's usually indication for surgery na. So, phakic emulsification with intraocular lens implantation. Kapag hypermature, it's also indicated na surgery na yan. So, phacoemulsification or ECCE or extracapsular cataract extraction. Extracapsular cataract extraction is when you remove the lens in its entirety. Parang hindi mo siya dodorogin with the phaco probe. And this is done in hypermature cataracts kasi yung ibang hypermature cataract masyado na sila makunat. Kumbaga mahirap na sila i-break down with the phaco. So kailangan ng ECCE. Next would be errors of refraction. So this is again very prevalent in the OPD. Clue mo dito would be yung pinhole acuity testing, no? So if the VA improves by 2 or more lines, more likely the patient has EOR or error of refraction. If it doesn't improve, no, think of non-refractive causes of decrease in visual acuity. So first would be myopia. It's characterized by good near vision, and management is basically glasses. So refraction, specific lens na need is concave or minus lens, and you may also recommend refractive surgery. But refractive surgery again is elective lang siya. So this is LASIK or yung SMILE. And caveat lang, no, for high myopes, those with greater than 600 yung grado, annual DFE is recommended. So, dilated fundus examination. Kasi kapag masyadong mahaba yung eyeball, in the case of high myopes, pwede siyang magkaroon ng areas of thinning or yung tinatawag namin na lattice degeneration. And this is usually kailangan niya ng laser, no? So, hyperope naman will be farsighted. It's characterized by good far vision. Pero ang mostly kinocomplain ng mga patients would be asthenopia or parang eye strain caused by headaches during close work, no? Kapag nagbabasa sila with computer use or with writing. Ang management again is glasses, specifically with convex or plus lenses. You can also do refractive surgery. Kapag presbyopia naman, so ang clue dito is the age and so more than 40 years old, and it's characterized by loss of accommodative ability of the crystallized lens. So parang hindi na siya kasing elastic as before. This is clued in by yung gradual onset ng blurring of near vision. Ang management, again, is convex lenses. So, reading glasses or bifocal or progressive lenses. So, you can actually, kapag may sinususpect kayong presbyopic patient sa OPD or during your Revalida, you could take yung trial lenses, kuha kayo ng +300 na convex lenses and patry nyo sa patient. If nag-improve yung Jaeger nila, you could be sure na presbyopia na yun. +300, that's the magic grado, kumbaga, for presbyopics. Next area of refraction, astigmatism. This is caused by abnormal curvature of the cornea, and it's characterized by blurring of vision, most described as distorted vision. Iba-iba sila ng description. Usually, ang description niya is parang may shadow. Pag pinapabasa mo ng letters, yung letters may shadow. Yun yung describe nila. Or minsan, sinasabi nila yung letters may buntot. Parang may buntot daw. So, yun yung picture on the bottom right, may kita mo parang what people with astigmatism would see. Parang ang may trail yung mga yung mga ilaw, yung mga signs, ganun. So another common complaint would be astinopia din. So eye straining, common with astigmatism. Again, management is glasses, this time with cylindrical lenses naman. So aside from that, you could also recommend kung gusto nila LASIK, refractive surgery. Next, hypertensive or diabetic retinopathy. So ang diabetic retinopathy and hypertensive retinopathy, hindi siya kumbaga yung magiging main diagnosis mo pag nasa OPD ka eh. Kasi parang ano lang siya eh, incidental finding usually. If your patient has diabetes or hypertension, magpa-DFE ka na doon sa patient na yun, no? Parang automatic na yun na you would screen the patient for diabetic or hypertensive retinopathy. Lalo na kapag first-time patient, no? Kapag new patient siya. Ang findings kasi ng diabetic and hypertensive retinopathy, it's wildly variable, no? Majority would be asymptomatic. So, kaya ako sinasabi na hindi siya magiging main diagnosis nyo. Kasi most people would be asymptomatic eh. Ang visual involvement niya only presents when there is involvement ng macular edema, if may hemorrhage na or may pagdudugo na talaga, massive na yung may vitreous hemorrhage na dun sa eye, or if may vascular occlusion na dun sa eye. Okay? So, nonetheless, it's important to study this for the Revalida kasi madaming patient ang may diabetes and hypertension. So for example, wala ka nang masabi about dun sa case mo. Pero yung patient mo may diabetes or hypertension, pwede mo na ngayon isingit yung discussion mo on diabetic or hypertensive retinopathy. No? So parang para lang may ma-discuss ka pa further, it's a good thing to study na, kumbaga. So if you are considering diabetic or hypertensive retinopathy, sa Revalida, it's always important to do yung direct ophthalmoscopy, no? So it's expected na wala kayong masyado makita with the direct ophthalmoscopy kasi usually hindi pa dilated yung patient and mahirap talaga makakita ng findings sa direct ophthalmoscopy. Mahirap talaga siya gawin, no? Pero ito na lang siguro yung mga i-emphasize ko na findings. So would be AV ratio and try to look for hemorrhages or exudates kung ano man makita nyo, no? Again, using DO, you will not be able to see the whole fundus. So that is why I said earlier na always recommend to do dilated fundus examination in order to kumbaga view the whole fundus, assess the whole fundus of the patient. So tips is to know the normal findings of DFE. No, so clear media distinctness margins, cup this ratio of about 0.3 to 0.4 would be normal. AV ratio of 2:3 and no hemorrhages or exudates. If hindi mo na alam kung anong sasabihin dun sa direct ophthalmoscopy, balik ka lang dito sa normal findings, no? So clear media is margins, cup this ratio 0.3, 0.4, AV ratio 2:3, no hemorrhages, no exudate. So memorize siya to. Memorize siya to, guys. Okay, so these are just pictures ng what you would see ideally sa patient with DM or hypertensive retinopathy. So you have that blood hemorrhages, hard exudates, flame hemorrhages, cotton wool spots, flame-shaped hemorrhages, hard exudates, no, dot blood hemorrhages. So if nakita niyo to sa direct ophthalmoscopy, edi good, no? Pero if not, then it's okay. It's not, kumbaga hindi siya yung expected na makita nyo at your level. So, I guess it would be prudent na rin to study yung grading. Di nyo kailangan i-memorize to. Ang mga ibibigay ko lang ng clue words, kumbaga, is kapag may AV ratio of 1:3, that's grade 1. If may AV nicking na, which is hard to see actually, that's grade 2, no? Kapag may hemorrhages, exudates, or cotton wool spots, that automatically grade 3, hypertensive retinopathy. And then if may papilledema, so this is kind of rare, so that's grade 4 na. Management, recommend strict BP control and referral to cardio na lang or family med or kung saan nyo gusto. Basta mag-control yung BP nila, yun yung important thing. For diabetic retinopathy naman, ang grading niya is divided into non-proliferative and proliferative. For non-proliferative, ang keywords na ibibigay ko sa inyo is microaneurysm for mild. Kapag may dot blood hemorrhages na cotton wool spots or exudates, moderate na yon. Yung severe, hindi masyado kailangan alam yan kasi medyo I don't think magbibigay ng severe DM-RET for Revalida. Okay, and yung proliferative, medyo ano na siya, medyo advanced na yung mga yon. Okay, so management would be strict glycemic control. And that means referral to endocrinology. No, so you can also refer to ophthalmology to ask for the intervention, which are as follows. No, kapag center involving yung macular edema, pwede tayong mag-inject ng anti-VEGF. Kapag nasa periphery naman or non-center involving, we could opt to do panretinal photocoagulation or laser, no? Kasi this is less invasive. Kapag meron namang vitreous hemorrhage, no, may pumutok na talaga na ugat na puro dugo na yung loob ng vitreous cavity. So, kailangan na mag-pars plana vitrectomy. So, this is a major procedure and it's most invasive. Pero ito na yung kumbaga yung last result. Last in the line, no? So final topic would be glaucoma. I'll make this very short. So again, glaucoma is basically optic neuropathy caused by which presents with the three features, which is optic disc cupping, characterized as a very high CD ratio, or if asymmetric yung optic cups. Yung left eye mo 0.3, yung right eye mo 0.5. So may symmetry of more than 0.2. You could consider that as glaucomatous finding na, suspicious of glaucoma. Other than optic disc cupping, you would also note visual field loss. So you could assess this with the confrontation testing. And then increase IOP. Again, I don't think pwede kayo mag-tonometry eh. So pwede naman siguro yung ano na lang, digital tonometry. Using your hands, ang normal again would be parang consistency ng tip of the nose. Ayun, ang diagnosis is mostly with ancillary tests. Specifically yung perimetry natin, perimetry 24-2 to both eyes, which objectively assesses yung visual field defects ng patient. And yung OCT of the retinal nerve fiber layer, which objectively assesses yung disc cupping ng patient. So, ang tip ko sa inyo, if may glaucoma patient kayo, may suspected glaucoma patient kayo, so mag-request na kayo ng perimetry 24-2 and OCT. No? So, halimbawa, nakita nyo sa direct ophthalmoscopy, may increased cup to this ratio of more than 0.4. Ayun, i-include nyo na sa management nyo na magre-request din kayo ng perimetry and OCT. So, for glaucoma patients, usually management would be to try topical muna, medical, no? In the form of Combigan and latanoprost if open angle. And you also ask a patient to come back monthly for IOP check. So repeatedly ina-assess yung intraocular pressure ng patient to make sure na controlled, no? Para lang silang mga high blood patients. Kailangan sila-check regularly yung pressure. And for repeat perimetry every 3 months. So that would be my last slide. Do you have any questions? Anyone has questions? Sige, ito.
Good evening po, Doc. So these are some of the questions coursed through us po, Doc. So the first one is, can we also drop by the OPD to practice using the slit lamp before our oral Revalida?
Pwede naman, yeah. As long as open yung OPD. Ano na kami, may bagong schedule na kami. Mag-open na rin kami on Saturdays, pero half day lang. So, ayun. Try niya lang saktuhin yung siguro mga hapon, kapag medyo konti na yung mga patients. You can use yung, I think yung papagamit sa inyo is yung Turks talaga na, yung Turks na slit lamp doon sa corner.
Thank you po,
Ayun.
Doc. There are also some other questions. If OPHTHA case, do we have to complete the full PE or can we just perform the OPHTHA PE? And in conjunction po, a related question, where in the OPD can we finish the rest of our PE, especially abdominal exam po, Doc?
Kapag off the case, I think it's is warranted na focus PE lang. Actually, lahat naman focus PE lang talaga. So if OPHTHA, kahit yung normal PE lang natin, visual acuity, Amster, Jaeger, slit lamp, yun lang naman. No need naman for yung very complete na PE unless warranted, no? So, depends on the case na lang siguro.
Thank you, Doc.
I don't think need ng abdominal examination in any case ng OPHTHA.
Sige po. Thank you po, Doc. Also, are we allowed to use the following things in the OPD during our oral Revalida? Jaeger chart, Snellen chart, panoptic ophthalmoscope, Amsler grid, pinhole, and fluorescent dye po, Doc.
Yes, pwede yun lahat. I think ilalabas naman yun, yung panoptic ophthalmoscope ni Doc Macaraig, yung mga dye nakalagay na doon sa slit lamp, may mga Jaeger chart naman and mga slit lamp, yung mga Amster grid, pinhole, occluder, ganun. I-prepare na namin yun.
Thank you, Doc. Last question po, Doc. What are the usual OPD cases you give to clerks for Revalida?
Ayun, yung mga in-include ko sa sa presentation. Kumbaga, nakasala na yun to the most common OPD cases, mga simplest na pwedeng ibigay sa Revalida.
Thank you po, Doc. I think that's all of the questions so far po, Doc. We'll just message again po, Doc, if there are additional questions.
Okay, sige, no
ayan.
problem naman. You know where to reach me naman. May mga, yung ibang group leaders nyo, still in contact with sa Viber ko. So, pwede yung i-course through them na lang. Or, ayan, kahit kay Nicole na lang.
Thank you
Sige.
po, Doc. So again, we'd like to thank everyone for attending this evening's review. And of course, thank you to Doc Balete. Kindly reminding everyone of our next review tomorrow at 4:30 p.m. for OB Gynae. Thank you po, Doc.
Okay, sure. Good luck, guys. Kaya niyo yan.